So it was kind of like a marriage of two things that I really obviously was very much interested in, being able to practice medicine and also being able to have time in the operating room.
Hi everybody.
Hi.
Hello.
Hi, everybody.
Shadowing.
Thanks for
Hi
joining.
everyone. Welcome tonight. Hope you're all doing well. Hi, as you all know, I'm Rodalyn and I'm the host for eShadowing. And tonight we have Catrisha Duret, and she is an OB/GYN PA. Thank you so much, Trisha, for coming on.
Thank you for having me. I appreciate you guys reaching out and finding means to give back to the pre-PA community. So I'm excited.
Thank you. Thank you. Awesome. I'm so excited to do OB/GYN and to hear all about your journey and how you and why and how you decided to get into PA school and the OB/GYN specialty. So
I'm excited.
we're gonna get right on. We're gonna get started. So can you tell us about your journey to becoming a PA and why you chose PA?
So I actually was a respiratory therapist first. I went to Stony Brook University in Long Island, and I always knew I wanted to either do physician assistant studies or become an MD. It just really depended on where I was in life. And life took me certain places, and I ended up doing respiratory first with the intent of going back to school, which I did. I had to retake some science classes that expired for about a year before applying to SUNY Downstate, which is where I ended up going in Brooklyn and graduating from with my master's in physician assistant studies. I decided to really be a physician assistant as opposed to an MD, which a lot of people always ask, because at the time I wanted to have more of a work-life balance, a better balance between my personal life, social life, and also my career, being able to have a career that was demanding, that paid well, that provided opportunity for some sort of autonomy and would allow me to really be able to interact with patient care, but also more so work in a medical-based approach and algorithm.
Awesome. So what made you choose the OB/GYN specialty?
So I was actually very anti-OB/GYN at the beginning. I did a talk last night and I was telling everybody that I really, really love surgery, and I tried to talk to my clinical coordinator and convince him to give me 2 surgery rotations and take away that OB/GYN rotation. That's how bad it was. And he's like, well, I did OB/GYN when I finished. That was my first job out of PA school, and I stayed in it for like 30 plus years. And I'm like, that is not going to be me. And lo and behold, I got on my OB/GYN rotation and I completely fell in love. Actually working where I did my OB/GYN rotation, it was one of the harder rotations, very demanding rotations. And because of that, I got to see a lot of different patient populations. I really got to be a part of different aspects of the team from the GYN side and as well as the obstetrical side. And I realized that there was a big portion of medicine as well as having time in the OR that I had no idea about when it came to OB/GYN. So it was kind of like a marriage of two things that I really obviously was very much interested in, being able to practice medicine and also being able to have time in the operating room. And, you know, being able to also provide care to women just like me, I think is always such an empowering thing to see a woman give birth and to treat any of your patients. But being a woman, helping empower women during, you know, laboring process and reiterating that they're made for it and built for it and they can do it. And, you know, seeing them cross the finish line and get to the stage 4 delivery is just really, really amazing each and every time. So I completely fell in love with that rotation. And here I am, an OB/GYN PA.
Yeah, I definitely have to agree with that, because when I did my OB/GYN rotation, it was the most beautiful thing, and just to see someone give birth, like just to see life come into this world, and for you to like be able to wake up every day and like see that, or you know, go through that process with a woman, see her through her whole pregnancy, like that's amazing. And thank you for that.
Thank you.
Thank you. So before we dive into your day in the life and just the whole OB/GYN specialty, I want to know a little bit about like your path to becoming a PA, because I'm sure they have a lot of questions about that. I know you were a respiratory therapist. How many hours did you have? Some of the tips you have for applying to PA school, getting into PA school, surviving PA school.
Oh gosh. Okay. So, like I said before, I was a respiratory therapist practicing for about 3.5 years. I gave myself a 5-year timeline to go back to school. And I decided to just, kind of reassess every year, every job, to see what I really wanted to do, if I wanted to go back, and exactly what I wanted to do. So I didn't waste any additional time or money, really. And one day I was sitting at my job, and a very good job at a very prestigious hospital. And I, was like, I don't really feel fulfilled in what I'm doing. I definitely have to go back to school. And I had a conversation with my now husband, then boyfriend, and said, you know what? We just started dating. And I said, I'm going to have to go back to school. Like, do you support me? It's tough. I was 29. I'm like, I have classes that have expired. It's going to be about a year worth of taking classes over. 29, sitting in classrooms with 17-year-olds and 18-year-olds in bio and chemistry. It's not it. It's not easy. Different things are at stake. So anyway, I got through the hump and I applied to SUNY Downstate. I was waitlisted the first time. I didn't complete my classes that I needed, that it had expired. I reapplied the second time. I was waitlisted again. And I was so discouraged. I was like, oh my gosh, how could I be waitlisted again? I was pretty sure I would get in. Last year, there was still a baccalaureate program. And I'm pretty sure this year they're going to be masters. I have to get in. I have to get in. It's in a good location in Brooklyn. It's in a very diversified area and it's close to home. That was my go-to school. So that was the only school I actually applied for because I was very determined to stay in Brooklyn, to work in a, pretty low economic area, to work around people and provide care to people that look like me. And so I only applied to SUNY Downstate for that reason. I thought that I may have had a leg up being a respiratory therapist, which I think in part helped. I was able to obtain my clinical hours from my work experience and also did volunteering with New York Cares, which is an amazing organization that provides various opportunities for volunteering all over the tri-state area. I'm sorry, the metropolitan area. For my school, it was about 250 hours, clinical hours that was required. And it varies from about 200 to 500 on average for these schools based on my research when I was applying a few years ago.
That's like patient care hours?
Patient care hours. 250 patient care hours. Yeah. I know some schools require 500 or more, but on average, about 200 to 500. And I believe it was about 100. I can't recall non-clinical hours. Something between the range of 50 to 100. I honestly don't recall. But New York Cares is a great organization I went through that provides a lot of flexible opportunities ranging from 1 hour to 4 hours all over Brooklyn, Bronx, and Queens. So it was very, very easy for me to, obtain those hours as well. I had gotten off the wait list and was provided the opportunity to come into SUNY Downstate. A funny story, I had called my mom and said, I was at work and I said, Mom, oh my gosh, I didn't get in. I'm so upset. I think it's a sign that I have to go to medical school. Like, oh my God, I have to take like the MCATs. I have to take a year for research. Like why is this happening? And so she's like, I come from a religious family. She's like, no, girl, get on your knees and pray. And I shut my office door and I prayed. And I kid you not, when I sat at my desk to open my bag and have my breakfast sandwich, it's like, hi, my name is Kenneth, calling from downstate. Are you still wanting to come in for the position? And I was like, thank you, God. So, yes, that's my interesting story. But I then went on to become class president of the first and they did in fact become a master's program. And I recall telling the chairman jokingly, that's why I didn't get accepted the first year, because you guys weren't a master's yet. And I really wanted to finish with the master's program. So, everything happens for a reason. So I went on to become class president and of the first master's class and do all these extracurriculars and such, provided opportunity with the program. And that's basically my background. Coming from respiratory definitely helped me quite a bit, especially in the didactic year. There was a lot of rigorous training that I received at Stony Brook for my bachelor's in respiratory. And I felt that there was a lot of came back that I didn't think I would remember that I did, even down to, EKG, which was very surprising to me, and anatomy, which we had as an entry course, anatomy cadaver lab. A funny thing, when I interviewed, I didn't expect this question, but I was asked, well, you already have a career as a respiratory therapist. Why should we give you a spot in the program? Why shouldn't we give the spot to somebody else that doesn't have a career at all and is coming straight out of undergrad? And I didn't expect that question. And, I try to maneuver my way around that and just express that, having clinical experience, I have an understanding that this is not where I currently want to be or see myself in the future, and that I'm kind of, searching for something more. And I think that essentially the PA profession will fulfill that. So I know there are a lot of people that are coming from other careers and transitioning from respiratory or nursing or from EMT, and also, wanting to career change and maybe faced with a question like that and kind of taken it back. So, it's a good way to answer that question also. So that's pretty much my background about getting into PA school.
Yeah, that was a curveball. I was reading the comments. Someone said that's a big curveball. That was, and you answered it really well.
I was so sidelined. I'm like, I was taking it back, like, give me the spot in the
program. Someone wanted to know, how many years did you work as a respiratory therapist, and how many hours did you accrue?
I worked, as a respiratory therapist, I accrued well over like thousands of hours. Yeah. I worked for about 3.5 years as a respiratory therapist at Columbia. I worked at North Shore, now Northwell. And lastly, I worked at Memorial Sloan Kettering. I worked as a sleep tech as a respiratory therapist, where I did sleep studies. And I've kind of worked in every subspecialty in respiratory as well. I worked about anywhere from 40 to even 60 hours with extra shifts and such as a respiratory therapist, which allowed me to thousands and thousands of hours, which was obviously very beneficial for my application process to PA school.
Right. I'm surprised that you even got waitlisted. You had so much experience, but the good thing is that you're here now.
Yeah, thankfully,
All righty. So we're going to go into the whole OBGYN segment, talking about your specialty as an OBGYN. Is that all you've done since graduating PA school?
So it's my number one job, but I also work as a surgical PA, where I work on my days off. I have a really good schedule. I work now Wednesday, Thursday, and Fridays. I don't work any nights, and I don't work any holidays. I don't work any weekends, which is really unheard of for a PA schedule. Usually PAs work flex days and nights, rotate holidays, weekends, etc. And
this is for OBGYN?
This is for OBGYN. It's a rarity, which is why I'm holding on for dear life.
Wow. So you have no surgery days? I mean, no on-call days?
No on-call days.
Wow.
Yeah. No on-call days. So it's an amazing position that, like I said, I'm holding on to dear life for. But it's a really, really good schedule that I have at the hospital that I'm working at. But that's not the standard across the board. As you know, obviously, you work days, sometimes nights, depending on the specialty, calls, weekends, holidays, etc. So that's basically it. And then on my 4 days off, I usually pick up my couple of shifts working at surgery in Queens, and I managed a floor there. So I was hoping that I would get OR time, but there's such a big
general surgery or
general surgery. Yeah. General surgery, and I manage, anywhere between 20 to 25 on average, rarely about 30 patients, but I manage those patients alone with the help of my nurses. And it's great.
Okay, wow. So for OBGYN, you have clinic days and surgery days, right? Or is it just all clinic?
I have only inpatient hours, so I don't work clinic.
Oh, okay. Yeah. Wow. So tell us about that. How does that work? Like, so you just for OBGYN, like you round on your patients and then, report to your attending. Can you tell us more about your day from clocking in to clocking out?
Yes. So I work OB and GYN. I know that there are a lot of PAs that either work either specialty. Usually they work in obstetrics or gynecology. And more recently, a lot of cross training is happening, obviously to the benefit of, the hospital or clinic, and also us as clinicians, right? It's just better for us to be able to work on both aspects, so that way we just have more of a clinical skill set.
Right.
So I work 2 days in OB and one of those days in GYN. So I do predominantly OB.
Okay.
And when I come in for OB, and it's all inpatient, so I don't work clinic.
Okay.
When I work in OB, I come in basically in triage, and that's essentially the pregnancy emergency room. So women come in, from home or from their doctor's offices or perinatal unit with obstetrical complaints, whether it's I don't feel the baby moving, or, I ruptured, or I think I ruptured, or I'm bleeding, or I don't have any amniotic fluid, or I have low fluid, or they need to be induced, or my blood pressure is elevated, and etc. So the nurses have those patients see them. They come to one of us, the mid-level providers. We pick up a patient, and we independently assess the patient. So I'll see the patient, do a history and physical, and assess them with whatever obstetrical complaints, formulate a diagnosis and assessment and plan. I then relay that to the chief of the floor, the department, and then I contact the provider, whether it be an in-house provider or the private provider of the patient. Hey, I have your patient here presenting with such and such, this and that and the third. This is what it's looking like. This is what I was thinking about doing for the patient. Did you want to do anything alternative, and et cetera? And we move forward and formulate a plan as to how we're going to manage that patient. Also, regarding obstetrics, Fridays we have what we call protected time for the residents. So usually they're away from about 8 to 12 on lecture, where we can also listen in. And at that time, the PAs basically run the service. We have the assistance of the midwives in triage, but there's about 3 of us PAs there, one picking up the antepartum service, one picking up the intrapartum service for laboring patients, and one picking up the postpartum service. And normally I pick up the postpartum service, along with seeing patients still that are coming into triage, which can get very hectic. So normally when I see postpartum patients, I'm managing the patients on the floor that have delivered after cesarean section or vaginal deliveries, providing patient education, home care, appointments, prescriptions, and et cetera, and any other complaints that may come along during the course of that morning. During that time also, usually Fridays are the days that I go into the operating room if things are controlled in triage. Then I'll go in and I'll first assist with any of the attendings that are in for that day, which is really exciting, and really what I'm really passionate about is getting into the OR.
Okay, and Fridays, that's your GYN days, or can it be a mix of GYN surgeries and C-sections, or?
So normally I just do C-sections.
Okay.
There's talk about possibly doing GYN surgeries down the line to assist on the days of Friday, because on the obstetrical side and gynecological side, all the residents are gone for that protected time during lecture. And so it would really lend a hand to the providers to have somebody be able to come in and first assist during their cases. But for right now, I'm only assisting in on C-sections, and also building up to be completely comfortable in first assisting across the board before I can go ahead and transition to GYN, which is a lot more versatility with the OR and the surgeries.
Okay, awesome. So they're already asking questions. How many patients would you say you see in a day?
So it ranges a lot on the GYN side. I work 1 day in GYN, and usually we have patients pre-post-op that we manage, and consults that we see coming into the ED, sent from the offices, or on the floor.
Okay.
That can definitely range. We can get anywhere between 0 to 5, 6 consults in a day, and have up to about 8 patients for the service that are usually a mix of complicated patients, especially if they're staying after GYN surgeries a lot of the times. For obstetrics, it can also range. Sometimes I see a few, depending on how busy of the day, maybe up to about 5 or 6 patients maximum, which doesn't sound like a lot. But when you're thinking about providing care to a pregnant patient and following through on plan and doing an ultrasound and getting an official ultrasound and doing labs and COVID and rooms, and it's a long process. So.
Yeah, and with you guys have to remember, with obstetrics, it's not ever one patient. You're always going to be caring for 2 patients at a time.
Absolutely.
That woman, and the mother and the baby. So you always have to consider that.
Yeah, absolutely.
There's a really good question. Someone said, I can imagine that women that come in thinking something is wrong with their babies can be very stressed out and anxious. How do you cope with that? And what are some strategies you have to calm your patients down?
Oh, this is like one of my favorite things to talk about, and I'm really passionate about because, a lot of people get jaded over time with patient care and see patients as just another patient or number, which I pray I never become. But I always try and make the patient feel comfortable and feel safe. A lot of times when speaking to the patient and they're nervous about, let's say, not feeling their baby move, or talking to them about possibly having a C-section, or even going over the risks and benefits of having a C-section, even though they're coming in scheduled for a C-section, just going over that with them before having them sign off on consent is very daunting and scary. So, right. I always tell moms, I'm sorry that you're crying and you're upset, but my role is to be as transparent with you as possible as your provider, and to have you feel safe and be aware of what's going on at all times. And although we're talking about, risks associated with this procedure, the most important thing is, one, you're at the right place at the right time, right? So you're coming in at a time where you don't feel comfortable, you don't feel safe, and we're here to assess you. And there's no better place to be than to be with us to properly care for you and assess you, instead of being at home or anywhere else. And also to keep in mind that our role, our number one role, is to take care of that baby and to take care of you. So any and every decision that we make together is to benefit the baby and to benefit you. And that's my number one job. And, we're here to help you along the way and support you. It's not an easy feat, but I'm going to remind you that you are a woman. You are blessed to do this. You are born with the ability and the strength to do it. So in the times that you think that you can't, remember that this is basically your God-given right. Like, nobody else can do it, right? Only a woman can bring forth, child, more or less. So, think about those things and remember that you're powerful and you're able to do it. And we're here to help you along.
Yes, so that's so empowering.
Yeah, I mean, because, I believe it, and I see moms and they're trying to push and they're like, I can't do it. And I'm looking them dead in the eye and I'm like, putting their foot on my shoulder. I'm like, yes, you can. Like, you're made for this. So you're going to take a big breath in, give me chin to chest, and you're going to push. You're going to focus on your breathing and you're going to count with me. And there's like something that fires up a mom to like really get those breaths in and push. And you feel so empowered to be a part of that. And it sounds sometimes so simple when you're in a room with a mom like that feels defeated. But, when you get that mom to have the energy and the drive to push, because it's exhausting.
Yeah.
It's just powerful. And then when that baby comes out and they hear that baby cry, it's like, you did it. And there's this like relief. There's this like happiness. There's this like empowerment. And I love.
Oh my gosh. That's like sending chills, because I can just picture it.
Oh yeah. I mean,
I'm sorry.
I had a woman with twins a couple of weeks ago, and we were delivering in the OR, and she was like, I can't. And dad is like, is the head there? Is that, like, barely trying to look over, like, is the head there? And I was like, the first baby is coming. And she's like, I can't. I'm in so much pain. And she looked at me and I was like counting with her, like 1, 2, 3. And I was like, just focus on me. Listen to me and your breathing. That's it. And she looked at me and we locked eyes and she's like, I can't. I said, yes, you can. You're born for this. And she took a big breath and she pushed. I'm like, let's go. Baby's head is right there. Let's get that baby out. Baby 1 is out. I was like, let's go. Baby number 2, chin to chest. You can do it. You're made for it. And she pushed and she's like, oh my God, thank you so much. And, just being a part of helping her breathe through the process, even though I didn't physically deliver, it was just in itself, just empowering to help her get through that threshold and that hump, And It's just amazing every time. Amazing every time.
It really, really is. Like, I don't even remember how many births I saw during my rotation, but it was always like, just like you said, amazing. Like I felt so giddy. I was always so excited to either do a C-section or see a birth. Yeah. I love the surgery days because of that. Or just
C-section's the same. Right. C-section's the same. I think it's a little bit more nerve-wracking because it's a surgical procedure and there's always increased risk and you just want that baby to come out. And when baby's out, you try to listen for APGAR, but it very quickly becomes like baby's out. Our concern being in obstetrics and gynecology is mom, right? So you want to be like, oh, baby's so cute. Baby's out, suction baby's breathing fine. Peds will take care of baby. We need to control the bleeding and get mom closed up and, and get baby and mommy, into recovery, and that's it. So
Right.
it's always empowering, no matter which direction it goes. To have a healthy baby and healthy mom is really a huge blessing.
Right. Oh my gosh. Thank you for that. Okay.
Yeah.
So, and another question I wanted to ask that also went along with some things I want to ask was about what are some common cases that you see in gynecology, and then like what do patients typically get admitted for, or when you round, what kind of patients do you typically see, or even patient population?
So patient population, I've seen more so in gynecology, a lot of African American women, honestly, in my roster in gynecology. A lot of the surgeries we see are myomectomies, removal of fibroids,
Right.
a lot of myomectomies to preserve fertility, basically.
Right.
A lot of fibroid removals in hopes that the patient can try and conceive and have a successful delivery. Depending on where the fibroid is and the size of the fibroid, it can actually impact your ability to conceive and get pregnant or maintain a successful pregnancy. So I see a lot of that happening, especially in what we call advanced maternal age. We have patients coming in their very late 30s or even early to late 40s having these surgeries to preserve fertility. And so that's just a sign that times are changing in, dynamics with women and when we try to conceive and the age at which we're conceiving these days. And you see that a lot, obviously, with the patient population. Also, we have quite a bit of gynec cases, a lot of endometrial cancers or cervical cancers, a lot of rare cancers also that come through the door. And we have a couple of really great gynec fellows, gynec attendings that do a really great job. A lot of times those patients are pretty sick, so there's usually another service on board with surgery or medicine or such, also managing that patient. So that's pretty much the gist of what I see in gynecology, along with a lot of the consults, which most of the time the biggest complaints in GYN is really abnormal uterine bleeding. And we see that a lot of times on the floor consults for, maybe advanced women in their 50s or 60s that are usually menopausal or perimenopausal, postmenopausal. And then you start to think, in that age range, when you hear bleeding, you want to rule out any type of suspicion for malignancy or cancers. And then we have women that come into the ED, and usually those complaints are due to maybe an ectopic pregnancy, large beta, they're in the office, there's no gestational sac visualized, or, what we call a surgical abdomen, or, complaints of pain, intractable pain, to rule out things like a torse ovary or, something like an abscess. But a lot of times you also see a lot of patients that are aborting that come into the ED with complaints of vaginal bleeding, unfortunately.
Okay, that's really cool. Let's see if we have any more. Yeah, of course, there's questions. Have you ever encountered a case that completely threw you off?
Let me think. Yes, actually. I'm thinking like if there's anything personally, there's always a lot of cases that I hear from everybody else, like the residents and stuff that are, introduced to the complicated stuff more so. I had a case one time. There was this, I feel like at my hospital, things come in like waves or trends. So this one particular month, I always ended up having, especially on Fridays, patients that would come in with complaints of vaginal bleeding and obstetrics, right? And then you hear that and you always get like, you got to kind of give yourself a pep talk before going in, like, okay, just like relax. Like, how are you going to assess the patient? Like, think about it. Okay, go and see that patient. So the patient came in, she was actually postpartum. And I always tell people to, a lot of people don't talk about the postpartum phase, and it's a very important phase.
Right.
So she came in and she delivered about 2 or 3 days prior, and she had a C-section. And she came in with complaints of vaginal bleeding, which is alarming. She didn't have any signs of what looked like to be an infection, with like anything regarding like endometritis or anything like that. It was just very concerning because it's like, why are you bleeding 2-3 days after you had a C-section, right? Because a C-section, you're manually removing the uterus. We take the uterus out of the cavity and put it on the patient's abdomen. We perform a manual sweep to clean inside the uterus and remove any additional clots or tissue to prevent bleeding or infection. And we obviously removed the placenta. And there's a little bit different viewpoint and scope when you're doing a C-section than a vaginal delivery, right? Because you're actually within the cavity. And so you can kind of do a little bit more manipulation than you would in a vaginal delivery. And so, you know, you're removing the placenta. And so you just like, what's going on? So the first thing I did, and that's when I kind of was a lot earlier on in my career. I've been practicing only for about a year, but it was probably about a few months in. And I said, okay, let me assess the bleeding. And this patient, I think she gave me about 1,700 cc's of blood right there in triage from the time I saw her. And that's not accounting, you know, what she probably bled out at home and on the way over. Right. And when I lifted the sheet and I assessed her bleeding, I said, she's actively bleeding. This is not like, you know, a little something. She's pulsating. This is active blood, active bleeding. And so I did a sonogram and I had to take a look at the uterus and I said, something weird is there. And I said, you know what? I'm still training my eyes. Let me call my colleague. And I said, hey, I'm doing a sono. This patient has bleeding. It looks like there's residual tissue in the uterus. Can you like, you know, double check my eyes? And she said, yeah, what is that? And then we looked at each other and we're like, placenta? You know, like, why would there be residual placenta when after a C-section is performed, right? Because you would remove it and then you do a sweep and make sure nothing's left. So we were like very puzzled, like, no, is that placenta? And so long story short, the patient was bleeding so much. We called the doctor. He finally came in. We rushed the patient to the OR. Her blood pressure started dropping a bit. She was getting pale. We called for like, you know, nurses to put in IVs right away to give her fluids. They took her so we used the balloon to try and kind of tampen out or stop the bleeding until we got her into the OR. You know, at that point, you know, calling the attendings, all hands on deck, and, you know, ran into the blood bank to get blood on the floor and all these things. So it turned into a, you know, situation of like, okay, bleeding, placenta, to patients going to the OR for a dilation and curettage to go in and basically kind of scrape the insides to remove any additional tissue that was there, because we were all perplexed. Like when I told the attending, it looks like there's placenta left. He's like, there's no way there's placenta left. She had a C-section. I'm like, look. And he was like, wait a minute, it looks like placenta. So we were kind of taken aback. The patient ended up having a uterine artery embolization. So the uterine artery feeds or provides blood supply to the uterus. Wow. And the patient was bleeding so much that we basically had to cut off that blood supply to help prevent her from possibly losing her uterus, which is very, very close to that happening. Thankfully, she did not. She did not have a hysterectomy and use her uterus, but she was very close to that. And I always tell patients the postpartum period is just as important, sometimes if not more, than actually the antepartum and intrapartum period as well, because a lot of things can also go awry after you actually deliver the baby. So it's really important, you know, to also pay attention to your body and what goes on after you deliver.
Wow. Oh my gosh. Yeah, that would have thrown me off too. And I'm sure like if she came in through the ER, like I'm sure people were like, what's going on? Like, why is she bleeding? But that was a very interesting case.
Yeah. I mean, it's like, oh, she's bleeding. And I'm like, okay. And lift that drape and, you know, I put the speculum and it was like, gush. And I'm like, oh, she's giving me like, you know, kidney basins of blood. I'm like, oh no. I ran and called that attending and I was like, we need to get an OR. Like, it looks like this is what I see. And they couldn't believe me because one, I was new, right? I was a lot earlier on and they're like, does she know what she's really looking at? And, you know, secondly, it's like unheard of, right? Like, why would there be placenta left after a C-section? You're manually extracting things. And so it's just something you don't hear of often. And so that definitely was an interesting case, to say the least.
Well, that was a really interesting case. Thanks for telling us about that.
Yeah.
Okay, so we have to get into the case study, guys, but I have one more question that I'm sure everyone's wondering about, and I think someone also asked, how did everything change with COVID? How was it like delivering a baby during COVID and just like the stress of it all, like with, you know, ensuring mom that everything's going to be fine, or just counseling mom or the parents during that time? Like, just let us know, like, how was it? Because I'm very curious to know how like OBGYN practices were.
It was, honestly, it was very scary. For whatever reason, I think that people just don't think that pregnant women can get COVID. people were just like, oh, COVID, OBGYN. I'm like,
oh yeah, there definitely were.
Get COVID. Everybody can get COVID, guys.
Yeah, there definitely were.
You know, yeah. So it was very, very nerve-wracking, because I think initially you always have that the anxiety of everything, because everything was very new to us and very scary. And so you hear constant pages overhead with codes, right? But then when the patient comes in and they're pregnant and they're desadding, you know, obviously, you know, things are a lot more intense, because you're worried about mom and you're also worried about the fetus. You know, is this fetus going to make it? How far along is she in this pregnancy? Is this baby viable? Is this baby doing okay? Put the baby on the monitor. Are we going to do a stat section or whatever? And a lot of those decisions, quite honestly, were made by the chief residents and the attendings on board, because it was such a high risk situation. You know, being pregnant in addition to having COVID, a lot of people didn't know what to do at that time. We were all learning and all navigating. And I quite clearly remember that one of our first big cases of COVID was a patient that a lot of us ended up seeing, because the patient kept coming quite often to the emergency room for complaints of early onset contractions. And unfortunately, she had a poor OB history where she had lost a child at a few years old and then lost a baby a few months old. And so, you know, she was very anxious and nervous to begin with. And I remember this was at the very beginning, where we didn't really know how effective masks were. And so we had a mask on, and that's when we were using masks for like a week and putting them in paper bags and, you know, recycling them. And she was a non-English speaking patient, and I used the translator services with the video, and I couldn't clearly hear her, and I had removed my mask, and she had removed her mask, and I was literally talking over her like this, you know, during the course of probably a good 30, 40 minutes to obtain a history and then perform her physical, maskless, to just clearly understand what it is that she was conveying, and the interpreter. And then I get a text message a day and a half later. Oh my God, Trish, you saw this patient that's COVID positive, that's now in ICU. We performed a stat section. Mom and baby were decompensating. And then the next day we're talking about the patient. The patient's in ICU. The patient is, you know, intubated. The next day the patient is now prone positioning. The patient has a history of diabetes, very poor health literacy, and poor compliance. And so we're thinking, you know, based on how it presents on paper, it doesn't look like she's going to make it. And I distinctly remember her husband looking at me, remembering me from, you know, the room when she came into triage, kind of looking at me to kind of, you know, look for something, kind of like, is she okay? Looking for answers, right? At that point, no one was allowed in, you know, during COVID. And he stood outside with a car seat, and I just like got chills. You know, is the baby okay? Is the baby going to make it? And is she going to be okay? And by the grace of God, she was okay. She was on her way off the vent. She self-extubated, and she did well, and she was able to go home to her baby. And a lot of our patients, thankfully, they ended up with a stat section. A lot of them ended up being okay. When moms delivered and they were COVID positive, they would be isolated from their baby. So they would deliver and C-section, and they wouldn't be able to see that baby for at least a few days.
All COVID moms had to have a C-section, or?
So COVID moms that were basically decompensating or not doing well ended up with a C-section.
Right.
Some of them delivered vaginally, of course. Everybody was gowned up, and it was very isolating. You know, obviously, you would take the patient, put them in specific designated COVID rooms, and then have to do like your whole, you know, specialized cleaning and such. And everybody was on edge because, you know, we didn't know when we were seeing patients who was COVID positive or not. And you go in with this anxiety and thinking, I'm going to swab this patient, hoping that I don't contract COVID. As you hear these, you know, codes being overheaded on the medicine floors. And thankfully, we didn't have a lot of mortality really, or I don't think any at all, actually, for our mothers that were COVID positive that delivered either vaginally or via cesarean section, thankfully. Babies that ended up having COVID also ended up doing well, thank God. And so far, so good. I mean, a big thing on my side was we wanted to limit interaction with patients to minimize exposure. So when I finished my training, it was at the very beginning of March, essentially, when things were really starting to pick up. And so I was not going into vaginal deliveries, and I was not able to go into the OR. It was really just the attending and a resident to first assist or another attending to minimize exposure to the rest of the team. And so that delayed my training really in GYN, because a lot of the GYN cases are pretty much elective, right? Unless somebody comes in and they're bleeding and they're decompensating and things of that nature. Also during COVID, the numbers show that a lot more people were ended up with home deliveries and home births because they were so afraid to come into the hospitals and for fear of exposure. And, you know, so that kind of delayed some of my training with the GYN. So there's still a lot more learning for me to do in general. But more so on the GYN side for that reason, having elective cases. You know, if you're pregnant, you're pregnant. That's never going to stop. So we always had patients come in on the obstetrical side to be assessed. Our census was definitely lower. Like I said, people were opting to do more home births, but we still had those patients come in.
Wow. So how is it now? Are like things, you know, kind of picking back up and there's getting to some level of normalcy?
Yeah, things are definitely picking back up. And I think for all of us in medicine, there's now a better understanding and grasp of how to properly manage a COVID patient with our experiences from past, you know, this past year and a half or so.
Right. And I'm glad you're okay, though, especially, you know, coming in contact with the positive patient so early.
Yeah, for sure. Thank you.
I'm sure it was a scary
experience. You too, because you work in emergency, right?
Yeah. Thanks.
Yeah. So, I mean, thankfully, both of us are okay. And a lot of my colleagues ended up being okay. Some had contracted COVID later on, but they're okay, thank goodness.
Right.
But now things are pretty much back to normal. We're back to our craziness in OB and patient population GYN. I think we usually have a little bit more of a load on the GYN side, but we definitely are getting back into the swing of things for quite some time. And like I said, we have a better grasp and understanding of how to manage patients. It's a little different being pregnant, right? Because like you said, you're treating two patients, right? And so you're always concerned with baby and you're concerned for mom and you want to make sure that baby's doing well. And because whatever happens to mom is going to in turn affect baby, right? So when mom is, you know, desatting or decompensating, it's going to obviously affect the baby's blood flow and the baby's oxygenation. And then you have, you know, those minutes to make a decision if you're going to, you know, wait to see it resolve and if this patient is sicky or if you're able to deliver this baby with a stat section, you know, depending on where they are and comorbidities and et cetera. So we have, there's better plans in place and strategies in place and how to manage these patients. And, you know, over time, we'll still continue to learn as COVID continues to change and, you know, we continue to develop research for it and everything. But thankfully, we've got a decent grasp on it.
Yes, thankfully. Thanks for the vaccine. Yeah. So there's still so many questions. I'm so sorry, guys. We have to move on to the case study. But I did put Trisha's Instagram in the comment section. Is it okay if they ask you questions and contact you?
Yeah, a lot of people ask me questions. I do like one-on-one interviews and stuff I have no problem. So you guys
I'm sorry guys, I can't get through all your questions, but feel free to DM her, message her, and ask away. Thank you so much, Trisha, for that.
Obviously, we went over through this part, you guys. My name is Catrisha Duret. I work in OBGYN. And just a disclaimer, obviously, that anything discussed is of my personal will and volition and opinion, not reflective of any platforms, organization, or my place of work. And we basically went over this a little bit also. This is a picture of an ultrasound that I actually did. Just the uterus here. I don't have a pointer, unfortunately, it seems. I wish I can kind of outline what you guys are looking at on here because ultrasounds are so super tricky. But I wish I had a pointer here. Unfortunately, it doesn't look like there's an option for a pointer. But if you guys text me about this or DM me about this, I can go over what you see here a little bit. So we're going to bypass that a little bit. And then we basically went over...
Sorry to interrupt you, Trisha. It looks like Elaine or a few people want to join in on the case study. So once they come... once they come on, I added Elaine. So once she comes on, she'll we'll have you kind of walk her through the case.
She's on.
Okay, so she's joined. So let's see.
Hello.
Hi, how are you? Are you a pre-PA student by chance, or are you in PA school, or?
I'm a pre-PA student. This is my first time attending like an eShadowing event.
Okay, nice. Welcome. Okay, so I'm just going to get into it. We have a 35-year-old gravida 2, para 1001 at 37 and 0. Gravida meaning the number of pregnancies, including current pregnancy, and parity. That first number is for full-term deliveries. That second number is for premature. That third is for any miscarriages or abortions. And the last is for any living children at home. So the patient, gravida 2, they're currently pregnant now and have been pregnant before once. Para 1001, meaning they had one full-term delivery and one living child at home. 37 and 0, meaning 37 weeks and 0 days gestation, providing to triage from their private provider's office and over for breech presentation. So I decided to go ahead with this direction, guys, because this is something I saw a lot in the last week. In one day, we actually had a few of these cases, probably about 4 in one day alone. And nobody really talks about this part as much. So I thought I would go over breech presentation for a little bit. Elaine, do you have any idea of what breech presentation is based on any of these pictures?
So I believe when a baby is coming out normally, quote unquote normally, it's head first, but breech is any form of presentation where it's not head. So like maybe arm, foot, butt first.
Yeah, pretty much. So we're going to focus on really term breech for the time being. And these are 3 really main breech presentations you're going to see: complete and frank, which have to do with basically presentation of the baby's buttocks and the legs in relation to the mother's pelvis. Okay, so when you see the complete breech, the legs are crossed and the feet are downwards, and the hips are basically flexed with the feet lying down by the buttocks or the hip region. In complete, you only have one leg in that position flexed downward, whereas in frank, you have both hips flexed with the feet facing upwards towards the baby's head. Okay, so how do we diagnose a breech presentation, right? So essentially, we're going to use an ultrasound. That's our objective way of kind of diagnosing breech presentation. Elaine, can you tell me by chance, how do you think we can diagnose on a pelvic exam? Because that is another option as well.
If the baby's arm or leg or butt is presenting, so physical indications, maybe, sorry, go on.
No, go ahead.
I would imagine the mother would be in severe discomfort, perhaps. And that's all I have.
Okay, so that's a good answer. So mom may or may not be uncomfortable. It depends on where baby's positioning is and baby's movement. So that's a good guess and a good answer. Also, if you're going to do a pelvic exam, mom may be dilated, right? So if we're able to get our fingers present inside the cervical os and we can actually palpate the baby, if mom is already starting to dilate, then we can actually feel for the baby's buttocks. We can actually feel a foot. We can actually feel or grasp onto a hand. And we can actually feel the baby's face. My coworker once said, she's like, this is really weird. I don't know what this is. And she ended up having her finger inside the baby's actual mouth because it was face presentation. So you can diagnose breech presentation based on a pelvic exam, which is a physical exam, more so an ultrasound, which is the more objective way, obviously, to do so, and also to determine the type of breech presentation. Okay, so modes of delivery for a term breech fetus. So Elaine, I'm going to ask you this to take a guess. Do you think you can deliver a breech fetus vaginally?
It would be really unsafe to do so. So my answer would be no.
Okay. And then you can answer the other couple for me too. Is it preferred to deliver via C-section? Is there preference more or less?
I believe it would be preferable to do a C-section. And for the third question, would we wait until the baby reorients itself, or if it can reorientate itself? I can see there might be a danger if the cord could wrap around the baby's limbs, head, or anything. Could be complications.
Okay, that last point is actually a very, very good point as well. Okay, so the answer is you can deliver a breech fetus vaginally. You actually can. There are certain criteria that has to be met, such as pelvimetry, the measurement or size of the mother's pelvis, right? The pelvic inlet, because the biggest issue with the breech is having the baby's head come first and then the shoulders, which is the widest part, right? Making the remainder of the delivery a lot more feasible and manageable. And when you don't have that orientation, it makes things a lot more complicated, right? Where we're worried about baby probably getting stuck in the inlet, baby being distressed, passing meconium, non-reassuring tracing, compressed cord, and all these things obviously happening with the possibility of a vaginal delivery. Some studies show that C-section was in the low mortality. There was a lower mortality for preterm deliveries, 3 to 1,000 versus 13 in 1,000 for a C-section versus vaginal delivery. Basically meaning that the study showed that if the cesarean delivery resulted in a lot less complications for the baby and for mom than having a vaginal delivery. Vaginal deliveries can be done for breech presentations. It's not always the best or the safest. You really have to assess it patient by patient. The best option in delivering a breech baby, a term baby, is probably in the frank breech presentation, okay? So that there's less chance of limbs or anything getting stuck in the inlet. But it is definitely something that's possible. If a vaginal delivery is failed during breech presentation, we would then call for a stat section at that time, but it is a possibility. Some studies also show that there is no difference really between doing a vaginal delivery and a C-section. There's a study that was done in France a few years ago, about 10 plus years ago. And so it really is provider dependent and facility dependent. But the last question, we can attempt an ECV, right? So the last question asked was, is there anything we can do before attempting a C-section delivery for a breech presentation to term? And an ECV is an external cephalic version. And I actually didn't learn about this until I started my OBGYN rotation as a student. And it's really an amazing thing that we can do with manipulation. So an external cephalic version is really essentially, this was a patient that we actually had last week. An external cephalic version is literally manipulating the position of the baby from the outside world and repositioning it from the outside world. So a lot of times the baby's an opposite pole where the head is at the fundus and feet are down, or transverse lie, we see if there's a way we can possibly maneuver that baby in hopes of preventing having a C-section. So that's really the final option before possibly having a C-section for a breech-termed fetus.
Sorry to interrupt. Is that similar to Leopold's maneuver? I remember that.
So we use Leopold maneuver. Yeah, we use Leopold maneuver to assess baby's positioning and move them accordingly. So the first maneuver we would look to assess for baby's head positioning. What pole is it located at the fundus? We look to trail alongside to find the position of the back, the buttocks, and whatever part is remaining in the pelvic inlet to determine the baby's positioning. And with the Leopold maneuver, that's how we actually do the external cephalic version. And this is done usually by the MFMs, the maternal fetal medicine specialists, or the provider, that's a generalist, and is comfortable and experienced in doing so. None of the mid-level providers actually do this, and I don't believe it's actually in our scope. I honestly wouldn't want to do it, even if it was. It is painful. It is very uncomfortable, okay? But it really beats the alternative, which is a C-section, if that can be avoided, which is obviously increased risk as it is a big surgery, and it helps along with preventing, being out for about 6 weeks in recovery.
Someone said there's a Grey's Anatomy episode, and then is there a risk of injuring the child?
So the risks really are, so I'm here on the next slide. The risks really are preterm labor, compression of cord, decreased non-reassuring fetal tracing, rupture, and things like that. Those are really the risks. Baby usually does okay, but before we actually do the external cephalic version, there's a few things we have to assess first, and obviously that's baby, right? We do what we call a biophysical profile to assess the amount of amniotic fluid that's present, which is really important. That's baby's habitat, and that allows baby free fluid and movement. And if there's not enough fluid, it's going to make it very difficult to maneuver the baby, right? Normally, AFI index is between 5 to 15. Anything really below that 5 mark is going to make it really difficult, and probably something that you don't want to do for risk of cord compression. Also, the same goes in the opposite direction. If there's too much fluid, you're worried about also baby flipping back into its breech presentation or breech state. So really worried about those things, especially with cord. And so, before we actually do the version, we assess the baby to make sure breathing is good, respiratory is good, assess for baby's actual position on ultrasound, and also assess for the amount of fluid level that we have to see if external cephalic version is a realistic option. So these are just some indications, absolute contraindications and relative indications as listed before. And these are essentially done at about 37 weeks gestation, which is the safe point where lungs have already been formulated. And it's at a point where if for whatever reason, external cephalic version were to fail, and we need to call for that section, this is a safer range within gestation of pregnancy to deliver with lower risk for morbidity for baby and for mom. Prior to that, we don't really do so because of risk for baby turning back into that position and also increased risk for complication prior to 37 weeks gestation. Okay, so some of the complications listed, placental abruption, fetal compromise, preterm labor, rarely but possibly is uterine rupture, fetal maternal hemorrhage, amniotic fluid embolism, and obviously fetal death. And we don't see that too much. It's a very small percentage. It's not even listed. But like I said, there all are complications that can arise. And I have here 2 pictures for you guys. You can see how baby's lying in the first picture with that yellow arrow. So baby is basically transverse, right? So baby's going essentially from west to east, the long side, right? And you see that arrow pointing at the baby's neck, where there's a hyperextension of the neck, which can also increase for complication. This position they call stargazing fetus because the baby's head is so hyperextended. And complications for this is cervical spinal cord injury. So this baby, you're not going to try to attempt a vaginal delivery, right? You may even try to do an ECV, but I don't know how effective that will necessarily be. And then the second sonogram down below to the right-hand side, if you guys can see, those are baby's legs, which looks like baby's actually in a free reach position where both legs are upright. Can you see that, Radeline? Can you see baby's toes?
Yeah.
I wish I had a pointer. So it's very interesting, to see on sono. Baby's buttocks to the far right. You see that dimpling and delineation, from the pelvis, and then you see the baby's legs extended there. Okay.
Sorry, is it the 2 little dots?
The 2 little dots. Which Elaine? Which picture are you referring to? The black and white or that brownish?
I'm referring to the picture on the left. You're talking about the positioning of the feet.
Oh no, the positioning on the feet is the second picture. That's kind of brownish and black without the arrow.
Oh, I see. All right, thank you.
Yes. Can you see it there?
I can see it better, I think.
Okay.
Thank you.
Okay. All right. So how do we prepare for an external cephalic version? So they're usually scheduled because there's a lot of planning that has to go into doing it. Sonogram, nurse along with a mid-level provider or an additional attending their resident, and abstain from eating 8 hours prior, having Orsoft available, and tocolytic agents, which are basically anti-contraction agents, such as terbutaline, which is used a lot, of Ritodrine. Terbutaline is really what we use at my facility. I think that's probably what a lot of people are using, which is a beta mimetic. And it basically helps to relax the uterus. So if in fact the external cephalic version goes well, that's great. If it doesn't go well and baby doesn't tolerate for whatever reason, or there's complications like a hemorrhage, then we're going to have to take that patient in for a stat C-section to the OR. So like any procedure, prior to surgery, you want to make sure that patients are NPO for about 6 to 8 hours to prevent, any vomiting and aspiration. You want to make sure you have an OR ready for a possible stat section and OR staff readily available. Nurse to obviously monitor and assess baby while the maneuver is being done, and another mid-level provider to actually assist you in doing the sonogram to reassess baby's positioning as you go with your Leopold maneuvers, and also just to kind of determine what the baby's positioning is if you feel that you've been successful. As mentioned, terbutaline is a tocolytic agent. It helps relax the uterus. Mothers can be in early onset labor or start contracting and still have an ECV attempted. And, if you think about it, the uterus is going to contract and create a lot of pressure. And its job is to kind of force and bring baby down. And so being able to kind of manipulate baby with a contracting uterus is not going to be effective. And so we issue terbutaline to help relax the uterus to allow us more room and feasibility to go ahead and manipulate that baby's positioning. Also, key of advice, this is also going to stimulate mom's heart rate. So usually when you administer the terbutaline, you expect mom's heart rate to go up and you expect them to be a little tachycardic. That's when you actually know the terbutaline is actively working. And that's actually when you go ahead and start initiating that external cephalic version. As you manipulate baby's positioning, what do you think you're going to do, Elaine, as we start to manipulate baby?
Are you speaking from like a provider standpoint and like a supportive
from a provider's
kind of standpoint?
point. So, I mean, if we're trying to manipulate baby's position to get baby head down, what tools do you think you can use to assess baby's positioning as you go along?
An ultrasound.
Excellent, an ultrasound. So as we go, we're gonna, somebody usually will assist the attending in doing a sonogram to reassess baby's positioning. Sometimes you take your hands off of that, baby for a second, the baby reverts back to its position or changes position, which happens, often. Okay, so what happens after performing an external cephalic version? If the ECV is successful, patients are going to be continued to be monitored after in triage, just to assess that baby's okay. Because in doing a lot of manipulation and movement, like I said, is very painful. You're causing stress to mom and you're also causing stress to baby from the external environment. And so we want to make sure that after, creating stress and, manipulation, that baby is still going to be okay and relatively stable after, and monitoring baby and monitoring mom, as well as contractions or any signs for any fetal decompensation or compromise. If the external cephalic version is successful, remember this is done at 37 weeks, then mom can go home after being monitored and come back for a spontaneous vaginal delivery, or come back with expectation to deliver vaginally, because now baby is head down, baby is not compromised after being monitored, mom is not compromised after being monitored. So now we would progress on with a plan for normal spontaneous vaginal delivery. If a failed attempt and mom and baby are stable, you can also plan for a C-section later that day if they're not stable, okay? If they are, you can also plan. It really depends on what else they present with. Okay, I think I just had a couple of questions for you guys. I think that asked this already. So I'm going to ask you, Elaine, can you deliver a breech baby vaginally?
Yes, with precautions
yes. Okay,
and everything
excellent.
done, yes.
Okay, awesome. And what is the name of the tocolytic agent that you should give prior to attempting an external cephalic version?
I forgot the name, but you did mention that it's supposed to relax the uterus and to prepare it.
Okay. Okay, good. So most important thing is you know what it does.
Yeah.
So
Yeah.
terbutaline. Excellent. Good. And then true or false, if you fail an attempt at an external cephalic version, you have to have a C-section right away.
Yes.
No,
never mind.
No. So So if you actually fail an initial attempt with an external cephalic version, you can actually try another attempt. If mom is stable and baby is stable and not compromised, meaning that their vitals are fine, she's not picking up in contractions, there's no signs of bleeding or hemorrhage, there's no signs of rupture, you can reattempt another external cephalic version. If mom continues to remain stable, you can try a couple of more attempts. Okay? Okay, so you answered these correctly. Very good. Okay, excellent. So, Elaine, do you have any questions for me regarding that first case, or was it kind of clear? There's a lot more things, Rodleen, also that obviously plays a role in this, but this is just kind of basically a superficial scheme of how we kind of manage these patients.
Thank you. No, that was an awesome case. Thank you so much. Thank you, Elaine. You did a great job.
Thank you for having me.
Thank
That was
you,
awesome.
Elaine. You did fantastic.
Thank you.
Thank you.
Someone want to know, how long does the whole ECV process take?
It depends on how willing that baby is to turn.
Okay.
We had an ECV the other day that was literally like 5 minutes.
Okay.
Like you can see baby's head literally come down and flip and just sit right in positioning. It was from outside. It's really amazing to see. I really wish that hyperlink was working for you guys, because you can literally see baby's head coming down. It's really amazing. And then sometimes it can take a little longer, like 30 plus minutes. I was in another ECV right after where we were all like breaking a sweat.
Yeah.
And mom was like in agonizing pain, like yelling for, you know, her provider to stop because she just couldn't take it anymore.
Wow.
And it was just, I mean, like I said, it's painful and it's uncomfortable. It does beat having a C-section if you can avoid that, obviously. But it also depends on how easy it is to manipulate the baby or how uneasy it might be as well.
Okay. So thank you so much for that.
Yeah.
So unfortunately it's 8 o'clock or it's 8:10
oh my
now.
God, that's fast.
Yeah, that was really, really fast. But I know you had one more case study, but I want to, of course, invite you to do that second case study later at a later date, whenever you're available again, because this was amazing. And I'm sure there's like still so much to discuss for OBGYN.
Yeah.
And there's so many unanswered questions. I'm sure your inbox will be full of questions. But we'll definitely bring Trisha back for the second case study, guys.
Yeah, thank you guys for having me. I know the first was a little lengthy, but I also find it to be very interesting. So
yes,
happy Women's Day to everybody, every woman out there.
Thank you. This was great for Women's Day. Thank you so much.
Yes, thank you so much for having me, and I'd be more than happy to come back and pick up with that second case.
Yes, I'm excited for that. Thank you again, Trisha. Happy Women's Day.
Sure, no
thank
problem.
you for all that
happy
you
Women's
do
Day.
for women all over. Thank you.
Thank you. You too. Have a good night. Thank you guys for joining.